So we're ready to open up the conference now. So this will be the part of the day where we have healthcare professionals from the London Centre coming to present. And it gives me great pleasure to introduce Professor Farida Fortune, who's the Clinical Director of the London BEHÇET'S Centre for Excellence. So please welcome Farida.
Good morning, everyone, and thank you. I thank everyone from the people who were here before and the people who will come after all of you. The organization has become, I've been involved with the organization for a very long time, and it's become very, very professional, and that's what you need to drive change and innovation in disease. So without you and the patients, we couldn't do any of this, and without my team, I couldn't do that as well. These are all the people in BEHÇET'S in London, those who work with the patients, those who work behind the scenes, the PhD students and the postdoc researchers. And I especially wanted to say thank you to Amal Sunusi, who was my PhD student, and now she's a data analyst. So today we're going to talk about the effects of BEHÇET'S, or COVID, on BEHÇET'S. Are you more likely to get COVID? What happens to BEHÇET'S patients? What did the research for our vaccination show? And the quality of life surveys. And we've been working very closely with the BEHÇET'S patient support, with John, and we've had 10 years to report. And then I think it's really important to talk about emerging infections. And as you know, or you might not know, COVID hasn't gone away. The new variants now have subvariants, and at present, of the big London hospitals, 3/4 of them are full, not taking any emergencies from any other centres, and I'm sure it'll get worse because we're 2.5 weeks from flu. You remember flu comes? End of October, November. BEHÇET'S patients know that because that's when the disease become active. Okay, so this was Madonna, and some of you have seen this. She and about 100 other people who have an importance in social life, who drive the agenda, started saying BEHÇET'S COVID was a great equalizer. And I don't know if it's going to play. We can't hear anything. I think just as well. All right.
How funny you are, how smart you are, where you live, how old you are, what amazing stories you can tell. It's the great equalizer. And what's terrible about it is what's great about it. What's terrible about it is it's made us all equal in many ways.
Oh, yeah? Oh, no, you're not equal when you're sitting in a bath with roses around you, yeah. And I counted 7 taps on the side, so it's a jacuzzi. Okay. It actually has been the great unequalizer. It deepened all health inequalities, and it has caused the first rise in poverty in 2 decades. And in 2020, we pushed 124 million into extreme poverty, and food poverty and security rose by 308 million, bringing 2.38 billion people into food poverty, right? There, for the grace of God, go I. It exacerbated existing health inequalities, and if you were younger than 65 and you lived in the 10 poorest areas in England, you're 4 times more likely to die of COVID. By mid-March 2021, the pandemic led to 119,000 excess deaths in the UK. So deaths that would not have happened, which were not COVID. And we had a 9.9% drop in the GDP. And so you can see with everything else that has been going on, there's been a COVID effect on the economy, as well as everything else that you know, but we're not in a good place. and we're not going to be in a good place going forward. So we do have to keep very positive and do whatever we can. And all of this was exacerbated by the heat wave, and climate change is here to stay. Migration in huge populations is here to stay. You know, we are a small coastal country. Don't think we are not going to be subject to floods. So if you look in the UK, in 21 we had 4.3 million with COVID and 127,000 deaths. We've now had 23 million patients with COVID and 181,000 deaths. So if you have a look, the deaths have come down, right? We've done well with the vaccination, and this year we've had about 75% vaccinated, which means our herd immunity will be quite high, and hopefully when people get COVID, it's not so severe and they don't die. And we're very lucky that Omicron, which is very infectious, the virulence is comparably low. But we've now in a subvariant of Omicron, and that's why people are getting COVID again. So almost everyone in this room is eligible for a vaccine. Please go and have it, all right? Because I'll show you how our figures have gone down for the patient group. So it's available now. Go and have it. And please, I always plead with people, have your flu vaccine, okay? Because you might not get flu, but you know that you get a huge flare. So if you get an injection flare, that's okay, all right? Because it will protect you from stimulating a hyperinflammatory response. You knew what COVID was before COVID was here, because that's your disease, that hyperinflammatory response. So we were also pushed into seeing much more online, and about 50% of the patients are online, and just slightly less face-to-face. I think the face-to-face for BEHÇET'S is exceedingly important, and I tried to keep the clinic open throughout COVID so that people who felt they were really ill could access it, even though patients would wait a long time to be seen. So how's the symptoms changed? So at the beginning there was fever, shortness of breath, cough, joint pain, and patients were very, very ill because nobody knew how to treat it. Even though we said this is like BEHÇET'S, damp down the inflammatory response, they were treating it like SARS. Now it's much milder with cough, fever, fatigue, joint pain, and really it's almost indistinguishable from flu. And with all these other viruses going around, you don't know if you've got COVID, you don't know if you've got another virus. And we've had all these other infections because of lockdown. When you mingle with people all the time, you see loads and loads of bugs, and your body habituates to it. So we're all in our hidey holes, and now I've come out, and now there is a huge problem. So it didn't matter what type of phenotype of the disease you had, right? You all experience the same symptoms. So if you were COVID negative or COVID positive, you see the phenotypic pattern is exactly the same. You do see, though, the patients who were COVID positive, who had active BEHÇET'S disease, were mainly the population that came from the Mediterranean and other countries, giving them a different ethnic background. Having said that, I don't think there's anyone in this room that has a totally Western Europe genetic profile. We looked at about 500, a huge number of patients of ours, and there was only one patient who was Northern European, right? So if you look at the waves of people who came in here, it's not surprising. So right at the beginning, when we looked back, we had quite a lot of patients stopping their medication. When we asked them directly, and they would ring, they were scared, they rang the website, and we're not compliant for a whole load of reasons. Sarah will talk about that later. But very surprisingly, and there was also a huge amount of confusion about shielding and not being able to go to the GP to go and get your bloods done. So the effect on BD, we had fewer patients per population than the general population without BD. So we're less likely to get COVID. We've had about 15 admitted to hospital. That says none in ITU. I've recently seen 3 patients in ITU. Actually, they weren't COVID. One had been admitted several times. They were actually active BEHÇET'S. So we'd infuse them very quickly within the next day, and the disease would start to settle down. So even when symptomatic, antibodies in these patients were totally negative. I talked to you about Omicron, and we really need to be very careful because the subvariant, which is BA.5.2.0x, there's loads of them. So now there's not only one kind of COVID around, there's many. Shielding at the beginning was very, very beneficial, and our patients didn't die because they were not exposed to COVID to get severe inflammatory flares. Okay, so when people do have COVID symptoms, make sure it's not a BEHÇET'S flare. Test and test and test. And in that case, you need an enhanced BEHÇET protocol. And I would say, please go forward and have your vaccination. It has made a huge, huge difference to patients not getting severe disease. And when your disease is active, much more manageable. So some patients said to me they were worried about, I had AstraZeneca and somebody had Pfizer. It didn't make any difference. You know, with the type of phenotype you had, the selection was random. So if you look at the number of doses so the AstraZeneca at the beginning, so the AstraZeneca is the pale blue, and the Pfizer is the sort of pinky brown. So you can see how that changed, and then the bright blue is the Moderna. And we can see that people from the third vaccine. The reason for this is we noticed that after the second vaccine, that AstraZeneca didn't give you enough as good a coverage as the Pfizer. So we now have the Moderna and Pfizer new formulation, which are very, very good at protection. You might get it, but you won't get severe disease. And if you do get it, remember, ring your GP, okay? You can have an antiviral. And there are several people in the room who I've seen who have had it, and it just switches the activity down. So did it make a difference if you were male or female, if you're younger and older, that when you had the vaccine, how did you respond? Didn't matter which sex you were, but you were younger, you had a significantly higher response. And as you got older, that's why you've been given boosters. Please go if you're older, because you don't make such a good response to the vaccine. And as I said, Pfizer was better than AstraZeneca. And the neuro-BEHÇET'S patients, you have to be really careful. And we've got Dr. Kidd here today, because those patients have not made such good responses, and they certainly need to go and have their second booster. And you can have a look at some of these patients. I think we've done 500 now. The younger ones are very good immunity. Everyone here, besides the one at the bottom, is over the bar. So you have a good immune response. But as you get older, it's less also, depending on the drugs that you have. So patients on prednisolone, cyclosporin, methotrexate, and cyclophosphamide do not make antibodies, right? So you need to sit down with your center and decide how you stop those to give yourself time to make antibodies and then restart your medication, all right? So the steroid up to about 10 milligrams okay. beyond that, that might be a problem. I think we should be careful and self-isolate when there's a lot around, and hygiene measures. So if you don't do anything now, just keep on washing your hands, because there's also loads of norovirus around. Do recommend the vaccination to anyone, and to be quite honest, if you look at the data, and one patient from Imperial said to me, I have 400 papers in 2 years on COVID, but if you look at all the data, there are millions of papers around. Vaccination is certainly protective and saved loads and loads of patients' lives. Okay, so long COVID. When people start talking of long COVID, we in BEHÇET'S know that long COVID a long time ago. I got someone sitting in this room who said to me, isn't this what I have in 2018 when we had months and months and I wasn't getting better? And if you look at all those symptoms, you do have the fatigue, and you do, after severe flare, quite a number of you might have symptoms of long BEHÇET'S. And the only good thing about this is now people believe the BEHÇET'S patients when they can't go to work because of fatigue, because they believe people with COVID. But if you have a look at that triad, the fatigue, the joint and chest pain, the breathlessness, brain fog, and the psychological things, isn't that the same? Right, and I talk in the research we looking and used AI and identified 2 molecules, so we hope to be doing a bit of work on that. So where are we now in October? We've just had a 1.74 million people infected, with a 31% rise on week. Okay, 1 in 35 people in England have COVID. Okay, we don't talk about it. The highest in the over 70 population, they're not going to have their vaccination, and the hospitalizations have increased with these subvariants. And it's very unusual because it's the only time that there's been a variant that then has a subvariant and a subvariant that causes a wave. If you look at Wuhan or the South African or the English variants, they more or less disappeared. Okay, so response to vaccines and medication, just very quickly, won't linger, but really it was just to say, if you're on prednisolone, right, talk to your clinic so that they can modify when you're having it. If you're having your infliximab, either delay it or have it and delay the vaccination. So you've got 3 clear weeks. You need 15 days to make antibodies. Okay, and that's simply said. So in summary, okay, only 8% of the BD patients of a 500 cohort had a low response to COVID vaccine. So it was good for all of you. And 3% of patients, even though they had symptoms of all sorts, never got infected. All right. The vaccine uptake by our patients is good, but with the 5th one, we're just pushing people to go forward. Those who did not, you're never going to persuade them. They're strong belief systems, political or otherwise, for not having it, right? And I think it's an important thing is we don't realize how many of patients don't take their subject. So now there's the emerging threats. Polio was eradicated in 1958 in America. We have polio. We had polio in this country, polio in America. In Africa, where it was supposed to have been cleared in August 2020, they now have 5 pockets of polio. But this is when you have this differential inactivated polio for one population and live polio for another. What's going to happen? The live polio, with increasing poverty and deprivation, is going to mutate, and then it's going to overtake the rest. So that's become a problem. Make sure that all your children are vaccinated. They should be, but just make sure. I spoke to you about the flu season, which is 2.5 weeks away, and the variant. So have your flu vaccine, okay? Even if you feel rubbish for a few days, have your flu vaccine. It's going to save you a lot, because the flu we're having is what's been in Australia over the winter, and that has been horrendous. We also had swine flu year, which we had a lot in 2020, but we had it again this year, right? We're very lucky that people were protected, and you saw the avian flu that killed thousands and millions of birds on all the cliffs around the country. Then monkeypox, we've had patients with BEHÇET'S with monkeypox, but again, it's been quite good. The disease has been very, very mild in the patients that we have had. Now, these are the diseases that are working their way towards us. Chikungunya, which, you know, you just feel terrible for about 6 months going forward. West Nile, which is awful. Zika, Ebola. So everyone thinks we got rid of Ebola. We haven't. Okay, and there's 2 clades of Ebola. There's one now sitting in Uganda, which is killing quite a lot of people. We were lucky with monkeypox because it was the Nigerian variant, which is quite mild. But monkeypox now in Europe, it's higher than anywhere it is in Africa. So I'm just saying that we have to be careful. You saw the floods last night in Nigeria, you know, destroying whole cities. You saw that in South Africa at the beginning of the year. The whole of Natal was underwater. Part of Maputo has already disappeared. You're right. We've got fires everywhere. I've got to be quick. Just the quality of life survey, which is IMPRESS at the moment, and that's done with the patient support over the last 10 years. And that will just show you, it will be IMPRESS, and you can see it, how the symptoms in patients have changed between the first survey in 2009. If you look at the pictogram, you can see that neurological problems, and that's taking headaches away, and stomach problems in the 20 survey has taken prominence, and things like oral hygiene and things in the patients have got a lot better. Okay, but the patient will be in Frontiers Medicine. It's IMPRESS at the moment. And then COVID, you know, I'm really quite important to work with Maslow's hierarchy, because that's looking at disease process from a patient point of view, and that paper's also with patient support with John's group, and that's will be in clinical experimental immunology. So that's good. Read it. It's from your point of view, and I would, you know, just. We have quite a lot of patients active, and I'd like to say thank you. So this is 60 miles from where I was born in South Africa, and this is what happens in winter. There's no rain. It's absolutely dust bowl. It's really awful. But just towards the end of it, we get these huge thunderstorms. So this is in the sky, and, you know, and somebody was sending around like, this is doomsday going to happen. I said, no, you know, and I was right, because look, what's happened? The pomegranates are starting to grow, and there's lemons on the trees. So nature always looks after itself, and we just have to become a bit more resilient and work with nature to see that, you know what, you have bad things, but then you have good things. Okay, so in the Bible, in the Hindu texts, in the Quran, it always says, after hardship, there's relief. Once we get into the hardship, we never look up. But look what nature does. Isn't that amazing? From one thing to the other. And we will all be okay, but we have to work together. And I am so proud of what everyone's done, because you've now worked in communities, and it's only when working together that you make a change, and change comes. I'm very happy afterwards to answer any questions from everyone. Thank you for listening.
So we're going to move on to Professor Ali Jawad now. He's actually not here, so he has done a video presentation. So this is why Ian is going to play it for me, because I don't know how.
Cheers. Hello. Good afternoon. My name is Ali Jawad. I'm a consultant rheumatologist and professor of rheumatology at the Royal London Hospital. And obviously I work at the London BEHÇET'S Centre of Excellence. I'm going to talk to you on aches and pains in BEHÇET'S. Now, there are 4 types of pain. Nociceptive pain or injury-induced pain. For example, if you bruise your arm or break your foot, you will get pain. Noci means harm, so it is from the acute inflammation that you feel the pain, and it's obviously usually acute. Or if you have an abscess or you have mouth ulcers, for example, this is also a nociceptive pain. The injury is caused by the inflammation, so it's referred to as inflammatory pain. Sometimes the pain is not associated with inflammation or injury, but damage to the nerve itself, as in patients with shingles. The nerve is affected by the disease, and it causes neuropathic pain. Another type of neuropathic pain is when you get sciatica, because the nerve is compressed. The nerve root is compressed in the spine by a herniated disc. This will also cause neuropathic pain. But in some patients, we can't find a cause to account for the pain. This is referred to as functional pain or neuroplastic pain. Generally, acute pain is pain which is less than 3 months in duration, and generally acute pain generally settles with a treatment or sometimes even without treatment. When the pain becomes chronic, the more chronic the pain is, as for example in patients with back pain, the more difficult for it to clear. So the earlier you treat acute pain, the less likely one would end up with a chronic problem. Now, BEHÇET'S, by its nature, it's a very painful disease. The mouth and genital ulcers are very painful. They cause a lot of discomfort. Some of the skin lesions are very painful, the erythema nodosum, the acne-like lesions, the pyoderma gangrenosum. These could be painful. Arthritis, if there is swollen joints, that causes a significant amount of pain, but sometimes there is only pain without swelling of the joint. This is more common. What we call arthralgia means pain, joint pain, but no swelling. Obviously, patients with neurological involvement, they get a headache, others get migraine, but in some patients, they have unexplained pain. It is not caused by ulceration or inflammation, and this is very difficult to treat. So if we go to if we talk about pain in the joints, generally when there is joint pain but without visible or palpable swelling, then this is referred to as arthralgia. And in fact, arthralgia is very common in so many diseases. If you have a flu, common cold, COVID, pneumonia, if you have other systemic diseases, colitis, any febrile illness could cause joint pain. This is usually due to the inflammation proteins that are secreted by the site of inflammation. For example, in BEHÇET'S, patients with mouth ulcers, especially if it's very extensive, some of the chemicals secreted by the ulcers could make you feel unwell, sometimes even slightly feverish, tired, and causes a lot of pain. But when there is actual visible swelling of the joint, then that is referred to as arthritis. It tends to be localized to the swollen or inflamed joints, and taking the fluid out, the inflammation fluid out of the joint, and putting some steroid inside the joint would relieve the symptoms. Some patients have pain unrelated to BEHÇET'S. I have seen so many patients who have other problems like hypermobility, and which is unrelated to the BEHÇET'S. But some patients with BEHÇET'S, they do have widespread body pain. Now, as we talked about the arthralgia, it is very common. It is generally related to active disease elsewhere, especially in the mouth, the skin, rarely related to the eye manifestations. It tends to respond to colchicine or anti-inflammation tablets like Nurofen, ibuprofen. Generally, once the ulcers heal or the skin lesions heal, the joint pain eases. While patients with arthritis, with the swollen joints, it occurs generally in about half the patients during the course of the disease when it's untreated. And sometimes the arthritis occurs months and months before the onset of the full BEHÇET'S syndrome or disease. And it generally affects the knees, then the ankles, hands, and wrists. It's usually self-limiting. As we said, it's very acute. It could last a few days to a few weeks, but generally, if you take the fluid out and put some steroids in, the patients feel better. When the patient is treated for the eyes or the mouth ulcers or the skin, generally the joint settles. It's very rare that the joint inflammation is the main features of BEHÇET'S. And again, it responds very well to anti-inflammatories or small doses of prednisolone, colchicine, and very rarely we need to use anti-TNF biologics. Joint damage is very rare. Pain unrelated to BEHÇET'S is very common. As in those who are under the age of 40, it's generally the hypermobile joints that cause the pain, and this is quite common. Also, there is another condition which occurs in teenagers or patients in their early 20s, is where there is roughening of the back of the kneecap. It's called chondromalacia patelli. In those patients, the pain is mainly on kneeling, climbing the stairs, or coming down the stairs. Sometimes there is a ridge, a developmental ridge at the back of the kneecap, which is called bipartite patelli, means that there is a partition, there is a ridge which separates the upper and lower part of the kneecap. And this again causes anterior knee pain. The other common cause which I have found in our patients is malalignment of the spine. It could be just a twist or scoliosis. And again, this scoliosis is not uncommon in patients with hypermobile joints. But older patients, those are older than 45, it could be the menopause. It could be the onset of the change. And in especially white Anglo-Saxon women or North European, it's the onset of early osteoarthritis. And in older patients, when the monthly cycle stops, they not only lose bone, but women could also lose muscle bulk. Nowadays, it has a name. It's called sarcopenia or myopenia, means weakness of the muscle. And you see, this is the reason why older women tend to stoop forward, because the weakness of the paraspinal muscles, and they have lost muscle bulk. Obviously, degeneration of the discs of the spine and osteoarthritis in the spine could contribute significantly. Very often, patients with any chronic illnesses like BEHÇET'S or or other rheumatoid arthritis, ankylosing spondylitis, colitis, hepatitis, they tend to be less well for a long time, and they forget to keep as active as possible. So exercise, lack of exercise, contribute to aches and pains, especially in older women. And there are other causes, of course. Now, widespread body pain, some people refer to it as fibromyalgia, which is really very common, and it occurs in up to 40% of patients with BEHÇET'S and other immune-mediated diseases. This is unrelated to disease activity, and if you try and give patients analgesia, they don't work. Even if you give them steroids, they may not feel better. Many patients end up on codeine, tramadol, or morphine, and again, this does not help the pain. Quite often, patients come into the clinic, they're already on butrans matrix patches, taking cocodamol and taking ibuprofen, and they are still in pain, which proves the point that this does not respond to analgesia, and therefore it is best not to use them and to wean oneself off them because they are addictive. And quite often patients feel tired. Sleep is universally poor in these patients. They get headache, they get irritable bowel, irritable bladder, painful periods, and they are intolerant of exercise. And if you do all the tests, they tend to be normal. In some patients, the fatigue is overwhelming. And so generally in those patients, we label it as a chronic fatigue. If there is more aches and pains, it's labeled as fibromyalgia. And it is a problem, and it is very disabling. But the treatment of these patients is not to give them analgesics. It's very important that these patients stay as active as possible within the limitation of their disability. They must eat well, a balanced diet. I'm not going to tell you what a balanced diet is. Everyone knows what it is. Adequate vitamin D. They must find a way of sleeping well. And many experts believe that really it's the lack of deep sleep causes the fatigue and the aches and pains in the morning. And in fact, we are at BARS, we are starting a sleep study, giving patients different gadgets to measure the depth of their sleep in patients with similar problem who have lupus or rheumatoid. And I'm sure at some stage we will probably do the same the same trial in patients with BEHÇET'S. Tai Chi has been positively shown to be helpful. Avoidance of opiates, especially codeine, tramadol, morphine, is very, very important. And there is evidence a small dose of an antidepressant like amitriptyline or propionine may help because it may improve sleep, but it doesn't work for everyone. And thank you very much. I hope to join you maybe at the time to answer questions. This is in Athens when I was chairing an immune-mediated disease symposium around 10 years ago. Thank you.
So I'd like to welcome Dr. Desmond Kidd up to do his presentation. So he's the consultant neurologist at the London Centre.
Well, hello everybody here and at home. Thank you very much for allowing me to talk. Those of you who know me well will know that 20 minutes will not be long enough for me to get through everything. I'll probably spend 20 minutes explaining why I'm not going to be able to do it in 20 minutes. However, I'll try and do it. And I've changed my slides. You'll also be pleased to hear, mainly to fit in with the remit of the talk today as well. So I'm hoping that they will be interesting, but it'll be glossing over. It did work, did it? No, I looked at the wrong thing. Okay, so the neurological complications that we have to deal with this condition involve inflammation within the brain. That's the most serious. Inflammation within veins, and we'll discuss what that means in a moment or two. Inflammation within arteries is more recently understood and previously thought to be much more rare than it actually is. And then finally, things which are not necessarily related to involvement of the brain, but which are nonetheless neurological disorders within the condition. Headache is extremely important, as we'll discuss, and then cognitive and so-called psychological symptoms. That doesn't necessarily mean that there's a psychological disorder, but the symptoms are most definitely within the remit of people who understand mental health problems. So we'll go through each of these in detail, and hopefully I will not have to rush through the last ones. But just to discuss that neurological involvement does not occur in everybody. Around about 5% will get some kind of neurological problem. It's more common within the first few years of the onset of the symptoms of the disease, apart from the ulceration, which everybody here knows even better than me, often precedes the onset of the disease by many years. Most of the patients have inflammation within the brain rather than inflammation within blood vessels. And most of those would have involvement of the brainstem, as we'll discuss. But it can affect the spinal cord, it can affect other parts of the brain, it can cause problems with what we call cranial nerves, which are the nerves within the head, which can be related to an isolated meningitis without it actually spreading in to the brain to cause inflammation. So we call it a meningoencephalitis. Meningitis means inflammation of the lining of the brain, and encephalitis means inflammation of the brain, the encephalon. About half of the patients would have inflammation within the brain stem. That's the area of the brain at the base of the brain, which acts as a kind of a relay in between the brain and the spinal cord and the rest of the body. So it's a very important part of the brain. It can affect other parts of the brain as well, much less commonly. And this funny title, Tumor Factor, is rather an accurate description. It means that it looks like it might be a tumor. And so the inflammation can be so severe within the brain that people sometimes are misdiagnosed initially as having tumors. A lot of these patients even have biopsies of the brain looking for what kind of tumor it might be, and then it turns out to be a BEHÇET'S syndrome. Whenever it affects the spinal cord, patients tend to have disorders of movement, sensation, bladder, bowel, sexual function, these kinds of things. That only occurs in about 10% of people who get inflammation within the nervous system. And then patients can get problems with the cranial nerves, any kind of cranial nerve. So the seventh nerve is the one which looks after the face. The fifth nerve is the one which looks after sensation. Other nerves look after the way the eyes move, causing double vision. The optic nerve can be affected as well, leading to loss of vision. So there are lots and lots of different ways in which the nervous system can be affected. And this is just an example, just to explain how it occurs. So what happens is you get inflammation in a vein, which is in the brain. It then spills into the brain from the vein, and then you get this whole big cascade of swelling and white blood cells coming in, which can sometimes destroy the structures, and it can be exceedingly severe. It's not always exceedingly severe, but it can be exceedingly severe, and it can be damaging, and it can lead to scar tissue in the brain, which is what gliosis is. We don't normally see the condition known as vasculitis, but as I'm going to discuss in a moment, as long as I don't run out of time, vasculitis rarely can occur. So these are examples, and these are obviously the brain scans, which are very helpful to us. I can't, for this, people looking at the other one will miss it, but there's abnormality here, which this is the brain stem, and it extends upwards, and this is a very characteristic lesion within the brain, which extends up, usually just on one side, but it can be on both. And this is a more extreme version. And you can understand why people sometimes are worried, if they don't understand Behçet syndrome, why some doctors think that people have brain tumours or infections or abscesses instead. And these are other examples as well. This is all the one patient. You can see that the abnormalities here and there and there as well. And this is a marker of inflammation where we give an injection during the scan, which if the contents of the injection leaks into the brain, that means that the brain is inflamed. And so it's a very helpful way of defining the nature of the neurological disorder. And obviously people like me have to make sure that it is connected with Behçet syndrome or its treatment, and because it's perfectly acceptable to have Behçet syndrome and another neurological disorder. So then inflammation within veins, this is causes blood clotting. So the patients with Behçet syndrome tend not to have too much problems with the blood itself, but whenever the vein gets inflamed, then the blood clots within the vein. And so in the brain, you can get it in the parts of the brain which are leading to the jugular vein and draining out of the brain, or the main venous sinuses as well, which are extremely important and determine pressure within the brain, for example, as well. You can also get problems with the consequence of blocked veins, but without actually seeing any evidence that the vein is blocked, and that's called intracranial hypertension. Patients usually present with headache and visual changes, occasionally stroke-like events as well. So these are examples then again, and if you look at this side, which is normal, you'll see that there's blood flowing through. This is what's called the venous sinus. But you see on this side, it should be the same, but there's nothing there. It's blocked off, and then you can see that there's blood clot on the brain scan on that side. And so that's what's called a venous sinus thrombosis. And this occurs in about 20% of people with neurological disorders which affect the nervous system. And then this is a smaller one, but it looks quite graphic on the scan, but actually it's just a little blockage of the vein there, and then there's back pressure, which is what you see with this big elliptical shape there, is actually not such a worrying problem. It's just fluid due to back pressure because the vein is blocked. Other veins then take over, and the situation resolves itself. So inflammation within arteries is very rare. 10 years ago was probably not really recognized very much at all, but we do recognize it better now, in part related to a greater understanding of the disease, more people researching it, but also in part related to having better and more accurate MRI scans as well. Patients tend to present with headache. They can have brain hemorrhage as well, and they can develop things called aneurysms, which are enlargements or ballooning out of blood vessels, which can occasionally be very serious. And they can develop strokes, or they can sometimes just find that these abnormalities have developed whenever people are having scans for the headache, for example. They can be so-called asymptomatic at some time. And this is an example. This is some where you develop it. There is inflammation in the brain stem as well, but you can see that there's a very dark area in the brain, and this reflects some bleeding which has occurred from an aneurysm, which is entirely caused by inflammation within the artery. So the reason we know that is because if people have aneurysms, then neurological surgeons often remove them. It's called clipping. So they go inside the brain, and then they temporarily block off the blood vessel, remove the aneurysm, and then sew up the abnormality. Whenever you do a histological examination, you can see that the blood vessel wall has been destroyed by inflammation, and it's very uncommon, but it definitely needs to be recognized before it causes any kinds of problem. Okay, so those are the main subgroups of the serious stuff that we have to deal with. the treatment, I think we're covering everywhere else, so I didn't feel I had time to go through all the treatment, but the main thing is that we need to treat the underlying condition vigorously and with recourse to all of the available treatments straight away should they be required. Headaches in Behçet syndrome are very common. 80% of people with the condition would have headaches. They have a tendency to correlate with the systemic features, but not always. They don't always settle as the systemic features are successfully treated. And most have vascular type headaches, which are migraines. So these are throbbing, pulsating headaches with photophobia, an intolerance of noise, a need to sit quietly and lie down. I'm sure I don't need to describe these to most of the people listening to me. And there's a high prevalence of associated debilitating symptoms. So, tiredness, cognitive changes, the need to lie down, the need to leave work and go home, the need perhaps not even to get out of bed in the morning in order to look after the family and to get to work as well. And they tend to be treated inadequately, but by the same token, if they are treated adequately, patients have run out of time. 5 minutes. It's a huge surprise. I thought I was going on 45 and everyone was been looking at me like this for ages. Most people who have repeating headaches in Behçet syndrome do not have abnormalities within the nervous system. The MRI scans are normal. If we even go to look at the spinal fluid to measure the pressure, for example, or to find out if there's meningitis, there tends not to be any evidence for that, which is a good thing. And to be honest, whenever, because people, I've mentioned headache with all the other more serious things, the headache is different, so someone has a headache for, once every 2 weeks for years and years and years. It doesn't mean they've got inflammation in their brain once every 2 weeks for years and years and years. The headache is different, and people like me can usually work out when we need to worry more about certain kinds of headaches than other ones. And so quite often, as some of you may have realized, I say, well, we'll have a scan taken because we need to make sure everything's fine, but actually let's just move on with treatment and get things done. And then hopefully, even by the time the scan is done, months later, the patient is starting to feel better. And we use the normal kind of treatments we use to prevent migraines. There's no particular difference. We often use anticonvulsant treatments, which are very good. Epilim, topiramate, gabapentin, there are lots of different ones. And we also occasionally use beta blockers, but not usually in grown-up or more elderly people. And then there are drugs which are very good for the acute headache as well, called triptans like Imigran and Maxalt and all of these ones, which hopefully those of you who know me will have tried if I felt it was necessary. And just like Professor Jawad said, the fewer painkillers people take, the better it is. Codeine always makes migraine worse. And some of you may have realized that I often say, well, we've got to get rid of the painkillers before we're going to make any progress with the treatment of the headache. And people often don't start to get better, even whenever we institute treatment, until the painkillers are stopped. Okay, so the last bit then is to do with cognitive dysfunction, which is very complicated and not fully yet understood, although we are working on this. And it is virtually universal. And again, I'm sure nobody here needs me to mansplain that to them. What we know already is that everybody with Behçet syndrome, actually, like Professor Jawad was saying, any kind of inflammatory disease has a problem with cognitive processing. So it's a slowing down of automatic cognitive functions, which are normally like this. You remember 10 things all at the one time. You go into the shop and you say, I don't need to bring a list because I know what I'm going to get and I know where it is and everything else. All of that gets much more complicated. There's no particular, with exceptions, there's no particular difference in the cognitive, I'm nearly finished, Jeff, thanks very much, in between people who've got neurological involvement and people who don't have neurological involvement. And then if we do tests for people with brain fog and things like that, we find that, thank God, a lot of the tests are normally okay. But there's a correlation with fatigue. People with any kind of inflammatory disease have associated problems with anxiety and depression. The prevalence is greater in people with inflammatory diseases, including BEHÇET'S syndrome. And you can even get different kinds of psychotic symptoms, which I think I've run out of time to explain, but I think Steve may discuss them after lunch. But he and I and everybody else in the team have got an understanding that it's not a mental health kind of psychosis. There are psychotic symptoms like hallucinations and disorganized patterns of thinking which correlate with the disease. And we can see this on this special kind of brain scan which looks at blood flow as well, and it correlates with abnormalities of blood flow within the brain, which appears to be related to disease activity. We don't yet know if it means that the blood vessels are inflamed, because if we do other scans, we don't find that they are visibly inflamed, but it may be a consequence to, and it's very likely to be a consequence to the inflammation that people see. And that's it. Yeah, those are the uncommon things. I was hoping to talk about them, but we can't. And we also, I should have added another interesting condition, which thankfully very few of you get, called enteric neuropathy, which is a very complicated thing, which we're also researching at the moment. And I don't have time to go through it, but I think I've gone through all of those things. I'm certainly happy to discuss those later on if anyone wants me to. Thank you very much.
Thanks so much, Dr. Kidd. So just before we break for lunch, just a couple of reminders. Remember fundraising. If you want to help us fundraise, there's merchandise at the back. Go spend some money. If you do have any questions for the medical panel, the little slips are on your table. If you flip them over, there's room to write questions. And also just a reminder to email John. So remember, he asked what works well, what doesn't work well, what do you want more of, less of, what can be improved. And you can email those responses to John as well. I think we'll put the email back up on the slide for break, so you can email him. And then go and enjoy some lunch. We're going to come back at 2:45. So the lunch is just outside. That way? That way. So out and that way. So go and enjoy some lunch. Enjoy mingling and meeting new people and saying hi.